and we'll get moving immediately. The image in the New England Journal concerns the fingernails of this nice 48-year-old man who presented to the emergency department with pain in his flanks. And somebody looked at his fingernails. And the differential diagnosis we're given is nicotine staining, splinter hemorrhages, an ungual melanoma, Janeway lesions, and onycholysis. Well, he doesn't have onycholysis. And these aren't, Janeway lesions aren't fingernail lesions. And you don't have melanoma of all fingers simultaneously. And nicotine staining should involve fingers 2 and 3. There may be nicotine staining, but the nicotine isn't responsible for these changes that we see here, and these are splinter hemorrhages. It used to be that mechanical typewriters were a common cause, but a more classical cause is subacute bacterial endocarditis. And as we see here, this patient didn't have bacterial endocarditis. He had what we call morantic endocarditis because he had a pancreatic adenocarcinoma. These tumors lead to a tendency to thrombosis that can occur on valves and can result in lesions of this sort. Smokers, fingers 2 and 3, no mystery there. An ungual melanoma might involve one fingernail and would look like this. Janeway lesions are flat macular lesions, as this one and this one, as opposed to Osler nodes, which are little microabscesses that are raised and painful. This is an example of onycholysis. This is separation of the nail from the bed, and the more common causes that I've encountered are a nail disease that's caused by psoriasis would be a possibility, but hypothyroidism would come to my mind, and there are other causes that are listed here. Splinter hemorrhages, endocarditis, classic, and my encounter with these has been as single lesions like this one, not multiple lesions as are shown in this example. The first topic in the New England Journal involves a transporter called SGLT2. There is also an SGLT1, which is largely present in the gastrointestinal tract, although there is some glucose and sodium reabsorption via SGLT1 in the kidney. It's responsible for less than 10%. So SGLT2 is the big transporter for sodium and glucose in the kidney. It's present primarily in the proximal tubule, and sodium and glucose are transported in a 1-to-1 fashion. And this transporter has become a target for drugs used to treat type 2 diabetes, such as canagliflozin. And as you can imagine, what happens with canagliflozin is that the threshold for excretion of glucose in the urine is lowered from the usual 200 milligrams per deciliter to perhaps some fraction of that, 120 or so that glucosuria will occur whenever blood sugar is above that level. But once the blood sugar levels have fallen to a lower steady state, then glucosuria should stop. And there is some natriuresis that occurs with inhibition of this transporter as well. So this is a canagliflozin study. There were 4,400 patients with type 2 diabetes randomized to a drug group compared to placebo group. I assume the placebo group got other medications that are commonly given for type 2 diabetes. And the primary endpoint was a microvascular endpoint involving the kidney. I hope they did some eye examinations, although these are not reported here. So the primary outcome was a composite of end-stage renal disease, dialysis, transplantation, etc., drop in glomerular filtration rate, doubling of serum creatinine, or death, or some composite. But there were secondary outcomes related to cardiovascular disease endpoints that I'm going to show you in a moment. Now, this study was stopped prematurely because of a positive result. And if we look at these patients, they're the age that we would expect type 2 diabetic patients with complications to be. And their various ethnic groups are represented, although most of these patients were white Caucasians. Some of them are still smoking. Everybody's got hypertension, but we know that. Some patients had heart failure, and they've had diabetes for about 15 years. These patients have vascular disease elsewhere, so amputations, etc. Body mass index is above 30, and we would expect that. Glycosylated hemoglobin levels were above 8, and their GFR is around 50. So what we see here is the primary composite endpoint was markedly in favor of canagliflozin. And the development of end-stage renal disease was significantly reduced. These significances, I think, are substantially impressive, but death from cardiovascular disease, now we're talking about large vessel disease here, myocardial infarction, stroke, etc., were also positively situated in favor of the group that got canagliflozin. Now, we know that SGLT2 inhibitors are associated with the development of diabetic ketoacidosis. We've gone over this topic before. It's not terribly common, but it does occur. So that occurred in 2% of the patients that got canagliflozin and only 0.2% in the group that got placebo. That was not analyzed statistically, but I can pretty well bet that this is a statistical difference, although the complication is not common. Clinicians have to be aware of this and have to look out for it. So here are the graphical displays of all of these, in my view, fairly impressive events. And even death from any cause was not significant as yet, but might be in the future. But these other endpoints here were significantly different, as are indicated in these panels. And if we look at different subgroups, level of GFR, whether or not they had proteinuria, etc., canagliflozin was definitely better. And what's also interesting is that the albumin to creatinine ratio in the urine was also decreased. And as we would expect, when canagliflozin is started because of natriuresis, increased sodium delivery to the macula densa, there is a slight decrease in glomerular filtration rate that's lower than in placebo. This is in the first weeks after treatment, but this then stabilizes, and then we see that the decline in the placebo group in glomerular filtration rate is greater than in the canagliflozin group. So this is a fairly impressive result, and this drug combined with glucagon-like peptide agonists should really have substantial benefits for patients with type 2 diabetes. You'll recall that the UK PDS study from 30 years ago had some favorable effect of metformin, but no other drug was useful for the treatment of type 2 diabetes, although much has been tried. So this is actually a very positive result, and I think it'll change the way in which type 2 diabetes is managed. The next topic in the New England Journal is chorea Huntington, or Huntington's disease. And here's a picture of Dr. Huntington. He was from Philadelphia, and here's his report from 1878. And he described the choreiform movements of these patients who develop uncoordinated, uncontrolled movement of upper extremities, alterations in muscle tone, and this development is also associated with the development of demence and death. So this disease is inherited in an autosomal dominant fashion. The penetrance is 100%, and so this is an awful neurological condition. Now, what happens here, as in numerous Mendelian inherited neurological diseases, the development of increased numbers of triplet repeats. And in Huntington's disease, the triplet is CAG. It happens that this triplet codes for glutamine. And if you have 11 or less, you're not going to have this problem. But if you have 30 or more, you're very likely to have this problem. And perhaps the problem is related to the increased numbers of glutamines that then occur in this protein. Now, the protein is called huntingtin, and we still don't know exactly what huntingtin does, although it's obviously it's present in the central nervous system, in brain cells. It seems to play a role in signal transduction, transport function, binds to other proteins, including in the cell nucleus. But we don't know that for certain. But since one of the functions of huntingtin is to protect cells from apoptosis, we could imagine that the protein is probably important. So in this study that I'm going to show you in a moment, an antisense material, an oligonucleotide, was applied in patients with the Huntington's mutation that did not yet have major symptoms of dementia or chorea, in the hope that the suppression of the synthesis of the Huntington protein, huntingtin, might be possible with this antisense treatment. And the endpoint here, this study is about safety, not efficacy, but the primary endpoint was safety. And this antisense oligonucleotide is delivered intrathecally. That means that these patients have to have a lumbar puncture every time that this drug is given. But lumbar punctures and the people that know how to do this procedure have improved substantially over the years. And so I don't think that the lumbar puncture is a major problem for the patients that are confronted with this disease. So this is not a randomized trial, but what you can see here is different doses of this antisense oligonucleotide were applied, and the schema is given in this graphical display down here. So the antisense is called HTTRX, and it was given in comparison to placebo in a dose range that's shown here, and it was given intrathecally. Now, the patients had more than 30 CAG repeats, that's shown here, so this is a positive indicator for the presence of Huntington disease. And their Montreal cognitive assessment scores were similar across the groups, and their motor scores were also comparable or similar across the groups. And since it's a safety study, the first thing that we're worried about are adverse events. And severe adverse events of grade 3 or 4 didn't occur in either the placebo group or any of the HTTRX groups, although there are some other adverse events, but we're not talking about lethal big-time problems that these investigators were searching for. Now, there's a dose-related concentration of HTTRX that's observed in plasma. So evidently there's some transfer across blood-brain barrier after this material is given, and the maximum concentrations that are seen in cerebrospinal fluid is shown in this upper panel of this graph. And indeed, with the administration of this material compared to placebo, there is decrease in the concentration of the huntingtin protein that's shown here, and that was the desirable effect. Now, whether or not the patients are helped from this treatment, we'll have to see in additional investigations, but at least it's an approach for this otherwise lethal, tragic, neurological Mendelian inherited disease. The next topic is endometrial cancer, and whether or not radiation, which is generally given to these patients, is of substantial value. So these patients with endometrial cancer stage 3 or 4A were randomized to chemotherapy, radiotherapy, or chemotherapy alone. And what we're interested here is relapse-free survival or tumor suppression progression of disease, if you will, and secondary endpoints are toxic effects and quality of life. And what we see here is that there are adverse events that are associated with this treatment, and gastrointestinal complaints and bone marrow involvement and fatigue and constitutional symptoms that are listed on the table here. And what we see here is in terms of progression-free survival or proportion alive and recurrence-free is the same in both treatments, so that it doesn't appear that the radiation therapy offered these patients anything in addition to the chemotherapy alone. And here are various subgroups that substantiate that point of view. Now, there are some differences that have to do with local node recurrence and things of this nature, but the primary endpoint in the two groups was not different, and whether or not pelvic or para-aortic node recurrence is of sufficient clinical importance to warrant use of radiotherapy, I don't know, but the details are shown here graphically. The next topic is metagenomics. And I'm sorry, I had no ideas what they were talking about, so I had to Google this to see what they're talking about. And what we see here is that the term metagenomics is a neologism, a newly discovered word that describes new approaches to the diagnosis of infectious disease. And metagenomics involves functional assays, DNA microarrays, lots of polymerase chain reaction, in situ hybridization, 16S ribosomal analyses, and whole genome shotgun sequencing. Sounds impressive. And in this study, also obviously in the New England Journal, these investigators used metagenomic next generation sequencing, that's what NGS stands for, of cerebrospinal fluid in patients that had suspected encephalitis or meningitis. And these patients also obviously underwent conventional diagnostic gram stain cultures, antibody tests, and these kinds of things, analysis of the cerebrospinal fluid. This ran parallel, and then these two approaches were compared by a retrospective chart review. So in the supplement, I found out what they're talking about and who all was included here. So any age, meningitis symptoms, encephalitis symptoms, myelitis symptoms, and the only exclusion criteria were psychiatric exclusions, presumably, or the patients didn't want this. I don't think that they cared one way or the other. And the patients couldn't be related to any of the investigators or students that were involved in this study. Now, the first result that interested me is that the metagenomics took 90 hours. And if the investigations take 90 hours, then I think I'd rather rely on gram stains, cultures, antibody tests, and inspection of the cerebrospinal fluid. But that was done, and you can look at the details. The patients are listed on this slide and where they came from, and et cetera, various things that were where these patients were recruited. And then I really don't understand how this is done, and I'm not sophisticated enough to be able to comment on this, but I'm sure that DNA was analyzed with next generation sequencing, and some RNA sequencing was also done. And then sometimes the investigators even sought clinical feedback. I would think that would be a good idea, and et cetera. And here are some more details on what was then eventually found in these patients, either with the metagenomics and also by conventional approaches. And I don't understand these graphical displays either, but I didn't really have the impression that the metagenomics is ready for prime time. So I think that we can give the investigators here an A for effort, and in 20 years we can see what happens with metagenomics, but thus far I think we'd better stick to the conventional studies instead of shifting to this kind of next generation sequencing on a larger scale. Now the reviews in the New England Journal, the first one is on anterior cruciate ligaments tears. And so first, when we look at study of this nature, review of this nature, we have to review our anatomy lessons, which for me was more than 50 years ago, but I remember what the anterior cruciate ligament is, and medial and lateral collateral ligaments, and the posterior cruciate ligament, and the patellar ligament, etc. And arthroscopically, anterior cruciate ligaments can be visualized very well. They're common, and the best diagnostic procedure to study these ligaments is magnetic resonance imaging, but there are clinical tests we use to perform look for a so-called drawer sign, but the Lachman test, which is rather similar, is more effective, and that's what this review is about. So this problem involves more than 50% of all knee injuries, 200,000 patients a year. It costs $7 billion, so this is a major problem. And the physicians that deal with these patients need to guide them through a decision-making process of should this be operated on and should it be repaired, or could we perhaps use a more conservative approach and then reevaluate this problem after 5 months and then make a decision whether or not an operative repair is necessary. And this also depends on the patient's age. Men and women are categorized somewhat differently. And then also what's important is how did the patient get this problem and what are his expectations? Somebody that plays basketball for a living is going to be handled differently than somebody that just casually slipped and fell, or even if he played basketball, if he only does it recreationally and doesn't do it for a living. In other words, what's needed here is what we now call personalized medicine. And so that is discussed here, and how the Lachman test is done and how it differs from the drawer sign that we were taught 50 years ago is shown here. But this is a pretty good clinical assessment of whether or not there's an anterior cruciate ligamental tear. And the diagnostic procedure, plain films are still done to see if anything else is broken, but the diagnostic procedure here of choice is magnetic resonance imaging, which has a marvelous sensitivity and specificity for this kind of injury so that it can be assessed. Then here's the business about personalized medicine. You know, what are the patient's expectations? How would he adapt to a more conservative approach? Can we expect the patients to comply with physical therapy and what otherwise would be done here? And is the patient willing to be assessed in 5 months to see whether or not he's been, the laxity is still of such a level that an operative repair is necessary, and that's discussed here. And the discussant also goes into where is high evidence, where is the evidence more limited, and what the areas of uncertainty are. And it's well worthwhile reading for physicians that deal with patients of this nature. The second review in the New England Journal concerns the management of Berms, terribly important topic. Lots happening here. And the acute management, of course, is to keep the patient immediately alive. So that an airway assessment has to be done because burn injuries obviously can involve airways or also involve inhalation of toxic gases and substances, etc. Then we need to assess the surface area that's involved here. And there are several approaches of this, a little more sophisticated than the rule of nines that I was taught in medical school. We have to make an assessment of the depth of the burn injury, and then we have to make an immediate decision in terms of fluid replacement therapy. And so this is all reviewed in this discussion by this expert. And the cicatrization that occurs that can be expected from some of these injuries and the contractions that are seen here, perhaps some other approaches to treatment would be better before lesions of this nature develop, and how epithelial healing occurs and the operative repair of skin grafting and sheet skin grafts and mesh grafts, etc., and split thickness grafts, and these technical details are also discussed in this review. And the nutritional requirements of these patients are given here in the supplement. There are some formulae that, if you're interested in this material, you can pull out the details here, but these are well known to patients that are involved in intensive care. Then this little case report, the 64-year-old person shows up in an emergency room because he's tired and dizzy. Looks like he's anemic. Somebody did a peripheral smear. And these are obviously lymphocytes, and they have these peculiar blebs on their surface. I've never seen anything like this either. But experts that look at a lot of patients of this nature recognize these peculiar blebs and reason that they might be T cells. And what we see here is from the further diagnostic testing in terms of surface markers of these T cells, identify these as pro-lymphocytic leukemia T cells. And we've learned in previous studies that there's now an antibody called alemtuzumab, which recognizes a marker that's present on T cells. And so the patient was given this wonder drug and he enjoyed a complete remission. Remember alemtuzumab because we're going to see it again later in the presentation. Here's the patients from last week that had this peculiar chest x-ray and this peculiar CT. This time they also show us electrocardiogram, and it underscores the presence of complete situs inversus. The electrocardiogram is classic, and so there's a follow-up on that patient. Then the case in the New England Journal concerns this poor 24-year-old woman that shows up with a pelvic mass and a positive pregnancy test. But what we see here is with this imaging, this is a CT, the imaging study that was done, there's a large pelvic mass, but it doesn't look like a fetus, and ultrasound also indicated that this is not a pregnancy, although pregnancy test is positive. This immediately leads us in a direction of ovarian cancer, and that's the discussion here. So the discussion concerns pregnancy and physiological masses. That's not the case here. Possible infectious causes of a pelvic mass, benign tumors, but with a positive pregnancy test, we have to reason with some sort of an ovarian cancer. And since the lesion wasn't cystic in this imaging study, I would guess that this is not a cystadenocarcinoma of the ovary, but it's likely to be perhaps a mucinous tumor. And so a biopsy was done, and this is an anaplastic carcinoma in association with an intestinal type mucinous carcinoma of the ovary. Whether or not this patient, I don't believe this patient had BRCA mutations, but that's also discussed in this case. And the management is unfavorable, and the patient's clinical course that eventually featured her demise are given in this article. Several weeks ago, we discussed briefly abdominal aortic aneurysms. Just wanted to draw your attention to the fact that the discussion is quite not so limited and simple as I mentioned. This is a report here from Berlin, comparing patients that were repaired with endovascular repairs that seem to do a little bit better than elective open repair. Once the aneurysms ruptures, the prognosis is obviously unfavorable. But this tissue can then be examined in terms of gene expression studies, and that gives us further insight into the development of this kind of severe atherosclerosis. And then the gene expression can also be mapped in schemata that are shown here, showing the interrelationship between the gene products of the various genes that are upregulated and downregulated in these aneurysms. Now, very recently, there was a meta-analysis published in the Journal of Vascular Surgery, and there's always the discussion, what's better, open repair or endovascular stenting, if you will. And I think that this is another reason to think about personalized medicine. Hippocrates said 3,000 years ago, it's more important to know what patient has a disease than it is to know what disease a patient has. So we have to tailor our decision making in terms of who is this patient, how old is he, what does he expect, what are his other risk factors, what else is going on in his life. And so in this meta-analysis, endovascular repair compared to open repair is different in different series that are reviewed here, but the authors draw attention to the fact that not all patients are the same, and we'll have to adjust our therapeutic thinking in terms of who is this person in front of me and what would be best for him. You'll recall that ruptures are more common after endovascular repair, but they're not very common. So if the patient is 85 years old and has severe heart failure and has a PO2 of 60, maybe endovascular repair. But if he's 59 and he has basically no other medical problems, and we're thinking of a long-term outcome over the next 40 years, well, I think you make my points made. In the Lancet, the first study that we look at is this one, which I thought was remarkable. This would have not occurred to me. This study was done in the UK, and it concerns actually vaginal deliveries. And should women after vaginal delivery receive a prophylactic antibiotic? And what was done here in 27 UK obstetrical units, the women were randomized to intravenous amoxicillin and clavulanic acid or placebo following their vaginal birth. And we look at these patients, and yeah, it's UK, and so they're different in ethnicities, and body mass index is different, and whether or not they've ever had a C-section is, but the randomization worked, and the two groups are basically similar in terms of their clinical characteristics. Now, to my surprise, confirmed or suspected maternal infection occurred in 19% of the women in the placebo group, and only 11% in the women that got this single dose of prophylactic antibiotics. And a whole bunch of other things were statistically significant. Superficial incisional wound infections were less, and deep incisional infections were less, and a whole bunch of things were statistically different in favor of using a single dose of this antibiotic for prophylactic reasons. And additional significant differences are shown here. So this is a large center, multi-center trial, adequately powered to robustly examine this question, and it came up with a positive result. Next topic is kidney cancer. Clear cell renal cell carcinoma. And we now have some treatments for that that are helpful. Tyrosine kinase inhibition, mTOR, which is not the topic here, PD-L1 inhibition, and anti-VEGF therapy. So in this large trial, the patients got PD-L1 and anti-VEGF compared to tyrosine kinase inhibition with sunitinib. And here's the randomization schemata. A lot of patients in this study, over 450 in each group, and otherwise there are various other clinical parameters were similar in the two groups. And what we see here is that progression-free survival was better in the PD-L1 inhibitor plus VEGF inhibitor group compared to sunitinib. This is progression-free survival. If we look at overall survival, there's no significant difference, and it's not great in either one of these treatments, but I suppose it was substantially better than doing nothing, which we were faced with 10 or 15 years ago. So there were some indicators that the combined therapy for PD-L1 and the anti-VEGF therapy were better than sunitinib. Maybe they should have tried all three. And you can look at details here, but these differences seem to be present in various subgroups that is shown here. And overall, progression-free survival was better in the combination treatment group. So that's the added value. The next topic involves fibroblast growth factor 23, which is a relatively recently new discovered hormone that's produced by osteocytes. And FGF23 is a phosphatoric hormone. So it blocks the phosphate reabsorptive mechanism in the proximal tubule, and it also blocks the synthesis of the active form of vitamin D, and it does these options fairly effectively, so that in patients with decreased renal function, FGF23 levels rise, and eventually, irrespective of their levels, they can not maintain serum phosphate within the normal range. And what we've also come to appreciate is that FGF23 is a risk factor, perhaps a general cardiovascular risk factor, but is also associated with some other diseases. And one of these diseases is X-linked chromosomal dominant hypophosphatemic rickets. This condition is also called phosphate diabetes. This is obviously a pediatric disease, and thank goodness it's not very common, and it's caused by mutations in a gene called PHEX. And we still don't know exactly how PHEX works, but it seems to have a role in regulating FGF23. And some details are shown here in these schemata that I've presented here. And children that have phosphate diabetes get bone disease, and it's a severe problem. Now, since they have elevated levels of FGF23, because PHEX isn't regulating it properly, perhaps this would give us a therapeutic avenue. And indeed, there's an antibody, burosumab, which is directed against FGF23, and this antibody was tested in children with X-linked hypophosphatemic rickets. And so this is, thank goodness, not a very common disease, but there were over 120 children that were randomized here, and they're from countries all over the world, and their phosphate levels are, as you can imagine, low, and they're generally treated with calcitriol and vitamin D formulations and sodium phosphate solutions and things of this nature. And what we see here is that the patients with this antibody against FGF23, burosumab, they did better. Their alkaline phosphatase levels go down substantially, and their total Thatcher-Ricketts severity is better, and their radiographic global impression of change is better. And if we bother to look at their x-rays, this is better than that. And so this antibody seems to work. And indeed, if we look at their serum phosphate levels, those rise to normal. And if we look at their tubular resorption of phosphate factored for glomerular filtration rate, it also improves substantially. And they even start making vitamin D again because they're suppressing FGF23 that impairs with vitamin D synthesis. And they even get taller and they're able to walk. And so this is a substantial advantage over what we had available. The next topic in the Lancet involves the transfer of HIV virus in couples where one individual is HIV positive and the other is HIV negative. And the question here is an antiretroviral therapy in the HIV positive person enough to keep transfer of this infectious disease from an HIV positive person to an HIV negative person? So couples were recruited who were divergent for HIV positivity. And they weren't all homosexual, although 97% of them were. 1% was heterosexual, and I guess the other 2% weren't certain. Needles are not the issue here. And so these patients were studied in terms of whether or not HIV was transferred to the HIV negative partner. And you can look at details of their sexual practices and their condom use and these various things. And what's surprising is that there was no transfer of HIV, with a few exceptions. And when HIV seemed to be transferred, sequencing was done to make sure that the HIV that was transferred was indeed what the partner had. Because perhaps the recipients of HIV were unfaithful. And if that were the case, they would get their HIV from someplace else. And that's why the sequencing that's shown in the left panel was done. And that indeed is what's shown here. So there were 15 new HIV infections. But the number that happened from the HIV linked transmission rate during eligible couple years was 0. So these transfers were from individuals that were unfaithful to their partners. The reviews in the Lancet concern gender equality. And genders are not equal. And that's the point made here. And this is relevant to healthcare because most healthcare today is provided by women. And that obviously includes physician healthcare because most of the medical students are women, at least at our institution, and that's true in all countries. And if the women have a lousy deal in life, it could impair their role as caregivers. And that's discussed here. And so this discussion here concerns genes and genitalia and body features and hormones. Okay, that plays some sort of role. And then race, class, age, ability, and gender differences in exposure, and these details are shown here. And in this first review, some key messages are given. And I disagree with the one that I circled here in red. This message says, although deeply entrenched, gender norms are not monolithic. I think they are, because I think the gender norms are dictated by the world's great religions. And the world's great religions are almost invariably led by men, and generally old men. And it's the religions that determine what the woman's role is in society, when they marry, who they marry, what they wear, and what occupations they're allowed to pursue. And the Western countries in North America don't have to be too arrogant about this, because 100 years ago, women weren't allowed to study medicine. And so the second review is the same issue. And this has a little more data, and it discusses socio-demographic index, which certainly plays a role in gender equality, although it's surprising how little this role is. Low SDI, that means poor, basically, with high fertility rates, that's in light green. High SDI is in dark green. And for all these disease conditions, there's not much difference. And for these various disease conditions, I was also impressed that there is not much difference. So gender inequality affects women whether they're poor or wealthy. Then there's some case studies here. Care seeking for childhood illnesses in Ethiopia, adolescent weight control in South Africa and Brazil, school peer influences on adolescents' health in the US, premarital sex and HIV status in Zambia, and these sorts of things. And you can look at all of these case studies, and I think they're interesting, and they certainly point out severe problems, but in no discussion was the role of religions even mentioned by these authors. So my conclusion is that these two reviews are amazingly politically correct. So those are the key messages. We close with two cases. The first one is this poor man, 35-year-old man who had originally was born and raised in Haiti. He moves to the United States and he gets symptoms of shortness of breath. Sounds like he has heart failure, but imaging seemed to show a lesion in his heart. Didn't know exactly what it was, but he had IgG levels that were negative for echinococcus, but positive for Taenia solium. And Taenia solium, that's the hog or pork tapeworm, and it can cause cysticercosis. And they treated with this patient with albendazole, and his lesion in his heart, you can see the details here in these nice imaging studies that are shown here, are better. Fortunately, he didn't have this problem in his brain, or at least the authors didn't mention that that was the case. The next study I think is also important. This concerns a patient with malignant melanoma that's treated with checkpoint inhibitor therapy. And this patient develops heart disease. Now, you might think that if we turn our T cells loose on our cancers, that they might end up chewing up things, some other things that we don't want them messing with. And one of these things is the heart. And one of the complications of checkpoint inhibitor therapy is myocarditis. So these malignant T cells attack this person's heart. But we've already heard that we have an antibody against T cells, because you saw the example in this patient that had this T cell leukemia. So we'll give our patient alemtuzumab, which was done here. And as you can see, alemtuzumab, which is directed against CD52, which is expressed on T cells, changed this ventricular tachycardia and some examples of heart block, but all of this went away with the alemtuzumab therapy. That's it for this week. If you'd like to hear all this in German, we'll do it for you in 10 minutes. Thank you for your attention.